Thank you for coming out. Now, this is great. I mean, this is a fantastic campus. I've never been here. It's a beautiful place, beautiful cancer institute. It's a fantastic thing. So probably some of you already know me, some of you probably don't. So I have been basically taking over the clinical developments of the Waldenstrom's program at Dana-Farber for the last 4 years or so. It was actually a match made in heaven, I would say, because what I wanted to do in my career is to become a clinical trialist, and really not to do a lot of laboratory work. I didn't see myself, surrounded by tubes and doing bone marrow biopsies in rats. That's not what I saw as my career. So when the opportunity to join the Waldenstrom's team came around, one of the first questions they asked me was, do you want to have any laboratory time? And I said, nope, I want zero laboratory time. I want to see patients. I want to run clinical trials, and it looks like that's exactly what they were looking for. So it has been a very nice enterprise, I would say, for the last 4 years, and with even more positive looks into the future. So Dr. Trion is in the laboratory. He's actually not seeing patients anymore for about 4 years, but he's in the laboratory working really hard on understanding all these biological issues behind Waldenstrom's. He's the one who identified the NYD88 mutation, the CXCR4 mutations, many other mutations that are coming down the road. And we are using that knowledge to translate it into clinical practice. Because one thing is what happens to a cell. It's very easy to kill a cell in a tube. It's very easy to cure cancers in rats. But when we try to translate that knowledge into human beings, there's a big difference. So we need to be very careful in terms of what we try, what we use, how we're going to do it, right? So that's where I come into place, to try to translate the science into an actual clinical benefit for patients. So that's what I've been doing for the last 4 years. And when I joined the group, they told me, well, you have 3 months to decide if this is what you want to do. It took me 3 weeks to actually make up my mind. And one of the main concerns that I had, and I want to be honest with you, is, I'm going to be seeing just one disease from now on. I was a blood cancer specialist, so I saw all the leukemias, lymphomas, myelomas. So that was what I liked, the variety of it. So when they told me I was going to see just one disease, and when I focus on just one disease, I was a little skeptical at the beginning. But very early on, I noticed that this is a different disease. This is not one disease. This is multiple diseases. We are just using this umbrella term called Waldenstrom's macroglobulinemia, but patients are very different one from the other. So all of a sudden, it's just not another patient with Waldenstrom's, right? It's a patient with a neuropathy, it's a patient with the anemia, the hyperviscosity, with the CXCR4 mutation. So at some point, it becomes the variety is so large that you don't feel that you're doing just one thing all the time. So for all those reasons, I'm really invested on this. I'm working with Steve Trion very, very close. And we're actually establishing multi-institutional collaborations to run clinical trials more effectively, more rapidly, to be more representative of what happens out there, and to actually provide treatments closer to you, if it's necessary. In any case, today we're going to be talking about what is new in Waldenstrom's. I want to give you a little background on the disease that probably some of you know, just to fill up some gaps probably. Then we'll talk about what treatments are standard. We'll talk about Ibrutinib, the data behind it. And at the end, we will talk about the new treatments on what is coming up. What is coming up, what is actually on trials, what is actually future trials, so you can get a sense of what this is all about. But before I start, I just want to introduce you my older daughter, Andrea. She believes that she wants to follow into my steps and become a doctor too. I'll do whatever I can to dissuade her against that, but I think she's pretty much decided. Andrea, that's right. Good. All right, so as you already know, this is my email address. If you have general questions, if you are my patient, you know that you can ask me questions all the time. If you are not one of my patients, you can ask me general questions. I will not answer specific questions. And you can always have your doctors, if they have specific questions, have your doctors contact us, and we're happy to help in a doctor-to-doctor communication. All right, this is the man, Dr. Waldenstrom. He actually described this disease in 1944. Very bright clinician, not only described Waldenstrom's macroglobulinemia, he described a number of other diseases, autoimmune hepatitis, hypogammaglobulinemias, immunodeficiencies. He was a very prolific clinician. He was being praised one day of all his, all the things that he had done in medicine, and he said, well, very humbly, he said, I'm a clinician. I just describe what I see. And that's exactly what we try to do as clinicians. We try to identify new things, identify patterns that will impact the care of patients. So how do we diagnose Waldenstrom's? And I have still patients who ask me, I have still doctors who ask me, what is this disease? Is it a lymphoma? Is it a myeloma? What is it? So by the WHO criteria, the World Health Organization criteria, this is a lymphoma. And the way we diagnose it is with these 3 features. Initially, we had only 2. We had to have a lymphoplasmacytic lymphoma in the marrow. Actually, 99% of the patients are diagnosed through a bone marrow biopsy. Few patients are diagnosed through either a mass or a lymph node that had been biopsied, but typically the disease is present in the bone marrow, so that's why we put that in there. And the lymphoplasmacytic lymphoma has a very interesting feature. You see lymphocytes that are abnormal, you see plasma cells that are abnormal, and then you see some cells that are kind of not lymphocytes and not plasma cells. It's something in between. Those are the lymphoplasmacytic cells that are very, very unique for Waldenstrom's. The second criteria is to actually have IgM protein that is on your blood. Now, 95% of the patients with lymphoplasmacytic lymphoma will have IgM secretion, but about 5% do not. They actually secrete IgG, IgA, which is another type of antibody, free light chains, either kappa or lambda, or some of them are actually non-secreting. They don't secrete any type of protein. Those 5% of patients are not Waldenstrom's. But we have no reason to believe that they should be treated any differently. So the diagnosis is IgG lymphoplasmacytic lymphoma or IgA lymphoplasmacytic lymphoma, not precisely Waldenstrom's. That has to do only with IgM. But the treatments are basically used for all of those in a similar manner. Now, starting this year, the WHO has included the MYD88 mutation as part of the diagnostic criteria. And again, we need to be very careful about this because we want to have at least 10% of our patients who will not have this mutation. And that doesn't, about 10%, who will not have this mutation, and those patients still will be Waldenstrom's. So I don't want you to feel that if you don't have this mutation, then the diagnosis is void. I don't think that's the case. So we're still, this is an evolving concept, but the first 2 are mandatory. And obviously having the mutation obviously helps in terms of increasing the certainty of our diagnosis. However, we talked about IgM, we talked about bone marrow. This is a study that was done in about 800 people with Waldenstrom's, and we actually plotted 1 dot per each patient depending on which IgM level they had and which bone marrow involvement percentage they had. But as you can see, we have people with almost no disease, 0%, all the way up to 12,000 IgM. And we have people with almost 100% disease right here on the right side, but all the way in the bottom with very, very little IgM secretion. So between patients, you should not be comparing your IgMs because the IgM for one person can mean completely different things as for the next patient that walks through my door. So you need to be very careful about that. Now, once we establish the relationship between the bone marrow biopsy involvement and the IgM in a patient, then we can follow that in that patient. So in that patient going from 1,000 to 2,000, it means progression. But if you compare patients to patients, obviously that doesn't really mean anything. And this graph, I think, is probably one of the most important messages as a patient. So you are not really, oh, you're 5,000, you should be very sick. We have people with IgMs of 7,000 who are completely asymptomatic. And we are treating patients with IgMs of 700 because those patients are symptomatic. So that really gives you an idea of how heterogeneous this disease is. Now, the survival of patients is improving, and we know that. Is it because the patients are being better patients? Is because the doctors are being better doctors, or the treatments are actually better treatments. So I think it's a combination of all those aspects. So in the graph on the left, we can see the blue line, the whole like continuous line, is actually the 1990s. That's the survival data on the 1990s, and we can see how the dotted line is the survival data in between 2000 and 2010. So that line has moved to the right, which means that patients are actually living longer. And this is about a 3-year change in the average. This is the average, 3-year change in the average of survival in the last 10 years. My sense is if we want to run this again, having 2010, 2011, 2015 data, which is coming out next year, so we want to be doing this analysis next year, I think that curve is going to be even further to the right. And that's just a representation of how patients are actually living longer. Now, the graphic on the right is basically showing you what the survival of the patients is depending on their age. Because the most important prognostic factor is age. The younger you are, the longer you're going to live. And that's how life is, right? So this is not groundbreaking, but it's interesting because, you know, if you tell a young patient your survival is 20 years, it's different than if you tell a young patient your survival is going to be 5 years. It's very different. And I still have patients coming to my office telling me, I have been told that I have 5 years to live. Should I start selling all my properties? Should I start spending all my savings? And I'm like, no, I think you should invest a little bit more, right? Because of this, patients tend to live longer. And I think these curves are going to move more and more to the right as time goes by. Now, as I told you earlier, the clinical aspects of Waldenstrom's are very varied. We have a lot of people, I think I would say about a third of patients that come to my clinic, they're completely asymptomatic. We call them smoldering Waldenstrom's. They have the disease, it's clinically irrelevant, it's not doing anything to your body. And then, you know, we basically watch those patients. But at some point, about 90% of patients with Waldenstrom's will become symptomatic. By me saying 90%, that means there's a 10% of people who will never become active. And we know that. So there's a group of people who will never transform, they will never progress, and they will remain indolent, and they will die of some other reasons. And the life expectancy of those patients is actually unchanged, as if they didn't have any disease, which is an interesting concept to understand. But about 90% of people will become symptomatic, and the most common manifestation of Waldenstrom's is actually anemia, right? Anemia is, I would say, probably 75% of the times when we need to treat somebody is because of anemia. But there are other reasons. We have neuropathy here about 20% of the times, hyperviscosity about 15% of the times, right? So there are different reasons why do we need to treat patients with Waldenstrom's. And the interesting part is that whoever has anemia sometimes doesn't have hyperviscosity, and whoever have neuropathy most of the times do not have anemia. So there are different diseases. They are different diseases. We're still calling them the same thing, Waldenstrom's, but they are really clinically very different one from the other. And we're trying to understand what makes some patients more prone to develop neuropathy and some patients more prone to develop anemia, for example. Now, what I want to clarify here is if you go out there in the world and you start just taking people randomly from the street and asking, are you anemic, are you neuropathic, you're going to see that anemia is very common. And there are many other reasons for anemia. And neuropathy is actually very common too. And there are many reasons for neuropathy. So the fact that you have Waldenstrom's and you have neuropathy, that doesn't mean that automatically the neuropathy is because of the Waldenstrom's. So when patients come to my clinic and they tell me, oh, I have anemia and my doctor wants to treat me, I was like, wait, we need to make sure that the anemia is not because of other reason. And we need to make sure that there's no iron deficiency, there's no B12 deficiency, that there's no destruction of the red cells, there's no kidney problems. Make sure that the only explanation for the anemia is the disease. Because I think we are over-treating patients up to some degree, and I don't think that's a good thing to do. I don't think we should over-treat, I don't think we should under-treat, right? Either by frequency or intensity. So there's a sweet spot that we need to reach, and I think my job for the last 4 years have been to try to define very well what that sweet spot to treat is. Because the more treatments you get, the more toxicity you're going to get. The more resistant your cells are going to become. So you really should be treated only when you have to be treated, right? And I think the certainty of the relation between the symptom and the disease is very important for that matter. So these are some of the reasons why we treat patients. As I said, anemia, low platelets, viscosity, Moderate to severe neuropathy, mild neuropathies usually we do not treat because those can go on for decades without affecting the patient's quality of life. Extramedullary disease, symptomatic lymphadenopathy. Some people have lymph nodes, but they're not symptomatic. They should not be treated. Or symptomatic renal involvement or pleural effusions or big Neal syndrome, right, which is when Waldenstrom cells actually get access into the brain, spinal fluid, can cause meningitis and things like that. So there are a number of reasons why we need to treat patients, right? But these are just guidelines. So we use this to decide who should be treated. But the decision at the end is between the patient and the doctor. As long as it makes sense, the patient should be treated. So let's talk about treatments. I mean, there are multiple treatments, and these are presented in no precise order of preference. But one of the treatments that we use very often is a combination of bendamustine and rituximab. Bendamustine is a chemotherapeutic agent. In this study, actually, bendamustine was compared to heavy gun chemotherapy. The Germans did this study. And this heavy gun chemotherapy is called CHOP. There are 3 chemotherapies plus a steroid compared to 1 chemotherapy that is bendamustine. And in this study, the red line, as you can see here, is a little bit more to the right than the blue line. That means that patients actually spent more time before they progressed if they were treated with bendamustine compared to being treated with heavy gun chemotherapy like R-CHOP, for example. So we like to use bendamustine. Patients do not lose their hair, they are not throwing up, they're not sick like they are with CHOP, for example. They don't have neuropathy problems and things like that. So it's a very effective treatment. 80% response rate, 20% complete response rate, a survival without treatment of more than 5 years. So really, those are really good numbers. But nothing in this life is perfect. It is a chemotherapy, right? So there's a tiny risk of developing secondary leukemia because of this. It's a very small risk. It's 1 in 200, but it's real and it's there. So we need to know these things before we actually decide to get into some type of treatment. The one that we have been using a lot as well since 2009 is bortezomib. Fantastic drug. Works really well when we combine it with Rituxan. Very fast responses. Again, response rate 80 to 90%. Complete responses 10 to 20%. Within 4 to 8 weeks, you have a decrease on your IgM. So these things work well and work fast. Very similar to bendamustine, but it doesn't give you secondary cancers, which is a good thing because it's not a chemo precisely, it's more of a targeted agent, but it can give you neuropathy. And we try to minimize the risk of neuropathy by giving it weekly, by giving it subcutaneously instead of intravenously. But still the risk of neuropathy is there. And as you get older, the risk of neuropathy is actually higher. Yeah? So we need to be very careful about these things. You need to be on steroids, you need to be on shingles prophylaxis for this type of drug. Again, good things and bad things. We need to have a balanced conversation about these type of things. Carfilzomib is a second generation bortezomib. It's intravenous. We're giving it weekly now instead of twice a week. No neuropathy, very good responses as well, very fast responses. You can see how the IgM drops very nicely within the first 2 or 3 cycles, right? But it can give you some other issues. It can give you, swelling on your legs. It can give you increased glucose, increased cholesterol. It can increase your blood pressure. So everything has a back and forth. And I think, bottom line, the message that I'm trying to convey is the treatments of patients should be highly personalized. We need to choose not only based on efficacy, but also based on the toxicity, based on your own profile, based on the medications that you're taking, based on the symptoms that you're having. What are the reasons that you need to be treated? So if we say, well, when I give everybody bendamustine, I don't think that's a fair approach. We need to consider all these options and trying to use the best options. The beauty about all this is if you try one, and then the disease relapses, you can try the other treatment the second time around, and then you can try the third treatment. So you don't really burn any bridges by trying one regimen versus the other regimen. Yeah?
So none of those options do you burn any bridges. You always have the option to try the other.
That's right. You always do, and that's a good thing. Having said that, rituximab, single agent, remains the most common used regimen in the United States when we talk about the community. In my practice, I seldom use it alone, for all these reasons, right? The patients can have an IgM flare. So if somebody has an IgM of 5,000, I'm not gonna give you rituximab single agent because your IgM is likely to increase even though you will respond, but at the beginning you will have this IgM flare. Patients can become intolerant to rituximab, meaning having more and more reactions as you get more and more infusions, which is not typical for most other lymphomas, but for Waldenstrom's, we have a 7% rate of this when we talk, and we published a paper on this recently, and when we talk about this with other doctors who treat lymphomas, for other lymphomas is 0.5, 1% intolerance. For Waldenstrom's is 7%. So it's actually much higher than for any other lymphomas too. This graphic is a little complicated, but I'm gonna make it very simple to you. Each bar is 1 year, starting 1994 to 2013. All the blacks are rituximab single agent. So you can see that in the United States, since the year 2002, 50% of patients in the community get treated with single agent rituximab without combinations. And it's not a bad drug, don't get me wrong, we love rituximab. Dr. Trion is the one who ran all the studies on rituximab. We use rituximab, we love it. But alone, we feel it's a little suboptimal. You know, we use it for other conditions, but in patients who actually need to have a rapid decrease on their IgMs, a good deep response, rituximab alone might not be the right thing. But when used in combination, it's actually very, very, very effective. So the approach to treatment, so maintenance a little bit about this. We are, proponents of maintenance, but again, it's personalized. The fact that I say, well, let's have maintenance in mind doesn't mean that 100% of my patients get maintenance rituximab. They don't, right? So I need to make sure that, how good was your response, how well you're tolerating rituximab, how many other side effects you're having of it, and what my goal is going to be, right? So yeah, we tend to recommend maintenance a little bit more than the rest of the centers in the United States, at least probably more than the Mayo Clinic. But even when I talk to the Mayo Clinic, even when I talk to them, they also recommend maintenance, but obviously at a lower rate. But it's not like it's not considered. So I think it's an option for some patients who need to have maybe a deeper response or not. In this study, we showed that the patients who get into maintenance have a longer survival free of progression compared to the people who did not get rituximab. Again, this is not a randomized study. This is not prospective, so it's all retrospective and biased. All our studies are biased, all of them. I want to be very clear about that. I'm the first critic of my own research. Why is it everybody biased? It's because the patients that come to see us, our average, the median age is in the early 60s. When in the community, the median age of diagnosis is in the early 70s. So our patients are 10 years younger than anybody else in the community. So all our studies are biased, just by that definition. So there is a German study, however, going on that is actually going to prove this or disprove this. And we're waiting for these results. Now, Dr. Buski has promised us that for ASH this year, which is the National Hematology Meeting, in December, he's going to have the first report in terms of survival, if it's going to be beneficial or not. So we're going to be waiting for those, very eagerly. So this is what treatment has been for us. You have an older brother talking to a younger brother saying, someday all this, my clothes and my shoes will be yours, right? And this is what essentially the myeloma and the lymphoma world has said to Waldenstrom's, right? All these medications that we've been trying in Waldenstrom's are medications that had shown to be beneficial, specifically for myeloma and lymphoma first, and then say, well, let's try it in Waldenstrom's then. No? So it has been kind of an afterthought. But things are changing. And then we have these new directions in Waldenstrom's that are driven by science, which is the most important part. One of the things that we discovered, actually this is the mutation that got me hired. That's exactly what it is, because they got published in late 2012, and then Dr. Trion realized that he will not be able to really carry on with the clinic and the laboratory with so much work to do in the laboratory. So that's why he started looking for a clinical guy, therefore me. So this is the mutation that got me hired. And this came out of Dr. Trion's laboratory, and he basically took about 20-some patients with Waldenstrom's, and he did a complete genome sequencing in all the malignant cells. And they found many things, but 90% of those patients had a mutation in this gene, MYD88. We all have the gene, but the patients who do not have Waldenstrom's, they don't have a mutation there. So that mutation basically activates this gene, and by activating the gene, your immune system gets activated, as if you were infected, but you're not. But your body thinks that you are infected all the time. And by that, secreting IgM is the first step in the protection against infections. And that's why your IgM just continues increasing and increasing and increasing with time. So when the study came out, the scientific community is very skeptical. And they say, well, we need to see if this actually gets validated. So this is the validation. This is at least 12 different studies from the United States, Europe, Asia. We have an Indian study, a Japanese study, and a Greek study in which actually showed that between 90% and 95% of all the patients with Waldenstrom's did carry this mutation, regardless of who you were and what you were doing. So it's a non-random mutation and happens in the large majority of patients. So this validated our findings. Now, we have gone beyond that now. And Dr. Hunter, right there in the picture, he actually identified a mutation on another gene called CXCR4, which is a gene that also has to do with mobilization of cells, not really immune system function, but a little bit more like mobilization of cells and how the cells know where to go, either to the marrow, to the skin, or to the organs. And that has to do with homing. We call it homing of cells. Now, the difference with this mutation is that when you think about MYD88, there's one spot that is always wrong. It's a point mutation. For example, it's like you have a sentence, and you know that one letter is going to be always misspelled, so you know where to look. In this gene, we have at least 30 mutations that have been identified. So you have the sentence, but people can have misspelled letters in different places, up to 30 different spots. There are some mutations that are more common, obviously, like everything else, but if you, let's say, prove that somebody doesn't have a mutation in that spot, that doesn't mean they don't have a mutation in another spot. So this testing is much more difficult to do, as you can understand. There are only 2 laboratories in the country that are doing this, us and the Foundation one. Nobody else is doing it. But it's an important factor too. Why is this important? Because of this. If you look at the 2x2 table on top, then we have either mutated MYD88 or normal. Wild type is basically no mutation, or the CXCR4 mutant or wild type. So we are actually theoretically 4 groups. There's one group that doesn't exist, in which patients do not have MYD88 mutations but do have CXCR4 mutations. That group doesn't exist. We have actually sampled about 600 people, and maybe one person has had that combination of mutations. And we're not even sure that person actually has Waldenstrom. So that group doesn't really exist. But then we can have people, double mutants, which is around 30% of the patients, people who have only the MYD88 mutation, which is around 60% of patients, and we have people who have no mutations whatsoever, which is around 10% of the patients. And when you look at this graph on the bottom, you know, the green and the red curve, this is survival, basically are the same. Those are patients with the MYD88 mutation, regardless of if they have CXCR4 mutations or not. So CXCR4 doesn't really tell me how long the patients are going to live. But MYD88 does, because if you see the blue line, the one that does not have MYD88 mutations, those patients tend to die a little quicker. Now, we are about to publish this research. We have actually collected data on about 60-some patients who are MYD88 wild type, meaning no mutations on MYD88. And they do have different signals. They have signals of myeloma, they have signals of marginal zone lymphoma, they have signals of other diseases. So maybe they are not Waldenstrom's. So we're trying to really understand that a little bit better. But research is ongoing. And I think that's the importance of actually having MYD88 mutation testing done. Now, the NCCN, which is the National Comprehensive Cancer Network, has actually established the MYD88 mutation testing as an essential testing for Waldenstrom's. So you should all at some point know what your MYD88 status is. And then this study came around. You know, we basically, by knowing how the MYD88 and CXCR4 work, they do work through this molecule called BTK, which is the Bruton tyrosine kinase. It's a specific, you know, enzyme in there. Ibrutinib is a BTK blocker. So in Dr. Trion's mind, it makes sense. If this disease is driven by MYD88 and MYD88 activates BTK, then maybe blocking BTK makes sense to actually stop the disease. And this is what drove this study. About 60 people, got included. Everybody had been treated previously. A lot of anemia, as you can see there. IgMs up to 8,000. Bone marrow involvement up to 70% in most cases. So, a group of people that I think is probably representative of the community, with the difference that in the community probably they will have been 69 years old instead of 63, so a little younger, but otherwise all the other clinical factors were very similar to what we see in the community. And this is the IgM. Each line is a patient. So you can see, and at the beginning, cycle 2, 3, 4, all the way to cycle 21, and we can see how the IgM really drops dramatically, very quickly within the first 4 weeks of treatment, we actually see an improvement in the IgM. And this is the hemoglobin as well, very similar. Within 4 weeks, we see improvements in hemoglobin too. in the large majority of patients, right? So you don't have to be a statistician to really see that there's a rapid response. And the patients obviously did feel better. If your hemoglobin goes from 9 to 11 in 4 weeks, believe me, you will feel better. If your IgM goes from 5,000 to 1,000 in 4 weeks, yeah, you will feel better, right? So not only physically, but also symptomatically and number-wise, this treatment was doing its job. And when we actually went and looked at the mutations, remember the 3 groups we just talked about, the double mutants, the non-mutated, and the MYD88 only, we saw, as you can see on the left, that the people with only MYD88 mutations had the best responses. 100% response, 90% deep responses, over 50% decrease on the IgM. The group in the middle is the double mutants. 80% overall, 85% overall, and 60% major. So a little bit lower response just by having the CXCR4 mutation. So CXCR4 mutations that do not tell me how long patients are going to live, but they're going to tell me who might respond better to Ibrutinib than not. Now, more research that we're doing now is telling us that maybe CXCR4 will also be an indication of resistance for other treatments, not only for Ibrutinib. And this is an important point because we didn't know that. We're actually learning there are people who are more resistant to treatment, and maybe those patients are the CXCR4 mutated patients. And then we had the patients with no mutations. There are only 5 patients, it's very small, but minor responses, nobody actually had a deep response. And those patients lost the response very quickly, right? So there are 3 clear groups when we talk about Ibrutinib. So when patients come to see me and they tell me, you know, I really want to consider Ibrutinib as my option for treatment, I'll say, well, we need to know your mutation testing. So in that way, you know, going in, how you're going to fare. If you fall into the great category, in the okay category, or the no way category, right, for Ibrutinib. So based on this information, right, compared to what we had previously, because I'm talking about an 90% response rate. This is what we were talking about with chemotherapy in combination with Rituximab. We're doing it with 3 pills per day, right? So the FDA got very excited about these results and approved Ibrutinib about a couple of years ago for the treatment of patients with Waldenstrom's. Now, the approval didn't say that the patients had to be treated or not. So theoretically speaking, everybody can be treated as long as they're symptomatic. Even if you were previously untreated or previously treated, you could actually be treated with Ibrutinib. But the scientific community says, well, but the study was done in previously treated patients, so then why I want to be using it in previously untreated patients? So for that reason, we started and almost completed a study on patients who have never been treated. And that data will be presented, you know, in December of this year. But again, nothing is perfect. And Ibrutinib also has its problems. And some patients are more symptomatic than others. Some patients do not have any symptoms. So we have a, you know, how can we predict who will tolerate Ibrutinib? We don't know. We don't know. But I like to divide the side effects between early and long-term side effects. The early side effects are the side effects that we will see in the first 2-3 months of treatments. And I would say maybe 50% of patients do experience those. Mild anemia, mild decrease on the white blood cells, mild decrease on the counts of platelets, some rashes, some nausea, diarrhea, joint pains. Typically by 2-3 months of treatment, those symptoms do resolve, or they become very, very minor to the point that patients feel that those symptoms do not affect their quality of life. Now, some patients will have more symptoms, but the large majority of our patients do not. In the long term are a bit more concerning from my perspective. So there's a high risk of bleeding with procedures. It's not spontaneous, with procedures. So if somebody's going to need, for example, a surgery, endoscopies, biopsies, things like that, we recommend holding the drug for a few days before and a few days after every procedure, each and every procedure, to make sure that they don't have a bleeding problem. Very much like we do with aspirin, right? We do with aspirin, we do the same thing. We stop it for specific procedures. There's a risk of atrial fibrillation, which is a very common arrhythmia of the heart. It's very common in the United States. I would say, I was just talking to a cardiologist the other day who actually happened to be the son of a patient of mine. And we were talking about Ibrutinib and atrial fibrillation. I said, well, the risk goes anywhere between 5 and 10%, depending on the risk of patients. He said, well, but the risk in the community is around 25% have people who have high risk. So how do you know if it's a disease or it's just the fact that people are aging and have other risks? I was like, well, we don't know, right? But this is what we're seeing and we need to report it for safety purposes. So yeah, patients who have heart attacks, history of arrhythmias, heart failure, they have a higher risk of developing atrial fibrillation, about 10%. But then we do have patients who go in with no heart problems. In those patients, really, the risk on those patients is less than 2%. So there's two groups of people. And even if you would have a history of atrial fibrillation, the 10% doesn't mean that there's a certainty that you will develop atrial fibrillation, right? It's a higher risk, but it's not a certainty either. It's not 100%. Hypertension is another issue. The more patients get into the study, the more the blood pressure can go up, and that can be treated. And we have not seen it in Waldenstrom's yet, but in other conditions, we have seen patients who have developed this pneumonitis, meaning inflammation of the lungs that is not infectious. And very rare, but we have not really seen it in our population much. Yes?
Doctor, if you, in my case, I have a history of atrial fib. I have CLL, not Waldenstrom. My wife's got the Waldenstrom, but this is obviously approved for CLL.
That's right.
So with a history of atrial fib, would this be counterindicated for me?
No, it's not. It's not. So obviously, number one, atrial fibrillation can be controlled. Some people are already taking beta blockers, anticoagulants. So if you're already getting the treatment, then really adding a medication that will increase the risk of having it, we will not change anything because you will continue with the same medications that you're on, right? I think it's a bit more problematic for people, for example, who do not have it, and then they develop it. And then that means that they have to be on medications for that, in addition to the medication for the Waldenstrom's or the CLL. So that could be sometimes a little bit of an issue. But first things first, if the patient has gone through pretty much every treatment and Ibrutinib is like the last thing they have, I will do everything for them to continue on that drug if it's working. If Ibrutinib is the first treatment you ever had, then there are many other options. So you can always say, well, if it's too problematic for you, we can always switch, right? So it's not a black and white. It really depends on where you are in the gamut of things.
So anticoagulants are not contraindicated?
No, actually it's not. Initially in the first studies when patients were on anticoagulation with warfarin, Coumadin, and there were some bleeding issues, a couple of patients actually had head bleeds. But I think it's because people didn't know that Ibrutinib actually caused bleeding. Now that people are aware of this, the monitoring is actually much more frequent. And we have patients who are on warfarin, Lovenox, the new ones are extra, and all these new medications, and no issues. As long as it's managed appropriately and around the procedures, shouldn't be an issue. It has not been a problem, at least in our clinic. We do have about 200 people in Ibrutinib in our clinic right now. Good, but there are new treatments. I mean, we have new medications. We have now oral Velcades. We have oral Carfilzomibs. There are new antibodies coming out for CD38. That's already approved for myeloma, and we're going to do a study on it. We have now antibodies against CXCR4. That's going to be specific for CXCR4 mutated patients. One more reason to know your status, right? Because if you have the CXCR4 mutations and Ibrutinib is okay, and maybe resistant to other treatments, maybe this is the study you want to participate on, to actually be in a medication that will block your CXCR4 mutation, right? There are other BTK inhibitors, second generation and third generation Ibrutinibs. There's this medication called Venetoclax, which we just completed a study on. So there are a number of different options, and these are driven by the science behind understanding MYD88, the science behind understanding CXCR4 signal. So these are the ongoing clinical trials at Dana-Farber. This is the one that I'm going to be presenting in December. This medication is called Ixazomib. It's actually an oral version of Bortezomib, given orally, much lower neuropathy, but the efficacy is still there. So 26 patients enrolled, 63 years of, 65 at initiation of treatment, anemia and the IgMs up to 5,000 and all. So really a good. So everybody was MYD88, and about 15% of patients had CXCR4 mutations as well. These were the criteria to treat. Most commonly anemia, about 50% of the times, but also constitutional symptoms and neuropathy and viscosity. So, a very typical population of patients. And we see here, this is after completing 6 cycles only. The study goes over a year and a half, but this is just the first 6 cycles because this is as far as we have gone for the analysis. And we see that the IgM already drops down by about 50% just within the first 6 cycles. And the hemoglobin improves as well as the bone marrow decreases too. And the responses are there too, partial responses, the large majority. We have some VGPRs. We just got 1 complete response so far, and that this is in the data cutoff that we did a little earlier today. And now this is the interesting part. CXCR4 mutations might actually affect the response to ixazomib. And this is the first time we're actually showing something like this. You can see on the left, the blue bars are the CXCR4 mutated, and the red bars are the wild typers. So there are more wild typers on the right and more WIMs on the left, which means that responses are actually more superficial on CXCR4 patients than not. And here on the right, we can see the blue curve getting a response really quickly. Those are the patients without CXCR4 mutations. And the red line starts responding, but it takes much longer to actually elicit that response. Those are the CXCR4 mutated patients. So we think that CXCR4 will not only impact how you respond to ibrutinib, but also maybe to proteasome inhibitors. And we're validating this information in bortezomib, carfilzomib, and see if actually that is actually true. But we have seen this in our study. As I told you, on the left, we can see the new Ibrutinib study in which 30 patients untreated had been enrolled. This data will be presented. I cannot give you too many details, but I think the data looks exactly the same as the previous study. So we are very happy about that. And I think the CXCR4 mutated patients, we will have responded, but obviously I think the response will be a little lower as well. What we're excited about is this one on the right, venetoclax. Venetoclax is a new agent that blocks a pathway called BCL2. All your cells have BCL2, and the amount of BCL2 they have determines how long those cells live. So we have cells in our body that live for 3 weeks, some cells live for 3 months, and that is mediated by BCL2. Waldenstrom cells have so much BCL2 that can be immortal, literally immortal. They can immortalize themselves. So if we give this medication, venetoclax, we block that BCL2, and then we force those cells to die. So very much like chemotherapy will do, but with a pill, right? So by doing this, patients are going to be taking 800 milligrams, which is 8 pills. It's a lot, 8 pills instead of 3 that ibrutinib is. But we think that within 2 years, we should be able to stop treatment. So this is not like ibrutinib, that you have to take it forever, right? So in the studies that we have presented, we'll present the data in next year when we complete enrollment already, but the initial analysis that we have done so far has shown that not only the IgM is dropping, but the bone marrow is also being cleaned up. We have seen bone marrows going from 80% to 10%, from 60% to 5% within 6 months. So yeah, I do believe that this is going to be the next best treatment for Waldenstrom's. And obviously, begs the question of combinations, right? Should we combine both agents, but to make a treatment that will be very effective but will not last forever?
And I would suspect the cost will be in line with the future.
Sorry?
I suspect the costs will be in line with the future.
That's right, absolutely. I think so, but the difference is, let's say if you charge the same for 2 years instead of charging the same for indefinite treatment, there's a big difference for the community, right? For society.
Has this shown any improvement in neuropathy and helping?
It's a little too early to say, and the reason it's too early is because neuropathy doesn't get better within 6 months, right? So we know that when the nerve endings are damaged, and we actually try to treat those patients, neuropathy takes about a year and a half, and actually see some clinical benefit. So it's too early for me to say that people with neuropathy do or do not get better. So we need more follow-up to actually answer that question. Good, and these are the planned clinical trials, and I think we're almost there at the end of the lecture. So these are the planned clinical trials. BGB3111 is a new generation BTK inhibitor coming from China. And they have already done some Waldenstrom's research on patients from Australia. And the data that comes out of there sounds very interesting. Now, they are running a study to see if really BGB3111 is as effective as ibrutinib, and they think it's actually less toxic. They seem to feel that it might not cause bleeding, it might not cause atrial fibrillation. I don't know if that's true. Those are just claims, right? There are some maybe alternative facts, we don't know. But we need to make sure that that's the case. So this study, this randomized phase 3 study, will basically put that to rest. So as a randomized study, patients will come to see us, and then we will randomly assign to one arm or the other arm. So you, as a patient, cannot select which arm you will be on, and that's a little bit of a downside. But that's how most studies, that are large like this is being done. It's going to be multinational. They already have it open in Australia. We're going to be opening in the United States. We're going to be one of the centers. I'm going to be the PI for that, and it's going to be open in Europe. So it's going to be a really large scale study. They're going to put about 80 patients per group. The beauty about this is that there is another arm. It's called Arm C. That's going to be specifically for patients with wild type MYD88. So if you're a wild typer, you will not be randomized. You will get the drug, and we'll see if the drug works on you or not, which is an interesting. The other two medications that we're trying, one of them is Daratumumab. Daratumumab is an antibody against CD38, which is a marker of plasma cells. In myeloma, it's really doing wonders. And we think that in Waldenstrom's it will too, because Waldenstrom cells do have CD38 in the membrane. So once we complete the venetoclax study, we're going to be opening this one. I think Daratumumab will open very shortly, within a month or so, at Dana-Farber. And it's just one year and a half of treatment. You are not going to be taking it forever either. It's just 1 year and a half. But it's a bit more intense in the sense that it's weekly infusions for 8 weeks, then every other week infusions for 16 weeks, and then monthly infusions for a year. So it's a little more involved. But we're going to have centers. We're going to have the Mayo Clinic open it, I hope. Probably Cornell in New York. Probably some place in California too. So we're going to try a little bit of representation from different places. And we're going to do about 30 patients. Obviously, when the companies like the studies and the studies are working out well, they extend to 40, 50, 60 patients, right, for FDA approval. I think that's what's going to happen with venetoclax. So let's see what happens with Daratumumab. But we're about to start that study. And the one that is specifically for CXCR4 mutated patients is this antibody called Ulocuplimab. I have no idea who come up with these names. I just try to memorize them. And use them the best I can without getting confused. But Ulocuplimab is an anti-CXCR4 antibody. And the way the study is designed is going to be in combination with Ibrutinib in patients with MYD88 and CXCR4 mutated status, either if you were untreated or previously treated. So this is the first directed therapy for CXCR4. And again, we're going to do around 20-some patients, depending on how the study goes. They might need some patients in the future. So, and this is just what we have planned. That is actually, we already talked to the companies, and we already have the molecules, and the contracts is ongoing. So these things that are going to happen within the next couple of years. But there are a number of other agents that are coming out that still in the laboratory, they're still trying to develop it. Dr. Trion is actually working on a very interesting molecule, MYD88, to actually signal, the mutated MYD88. It needs to actually bind to another MYD88. It likes itself very much. It's very narcissistic. So it basically binds to itself in the membrane before it signals. So there are 3 links for those molecules to actually bind together. There are 3 links. And there is one link that if you put a molecule in the middle as a blockade, it doesn't allow the binding to occur. And if we do that, we might actually stop the MYD88 from even firing in the first place. So this is what Dr. Trion is working on at this time. And it's actually, I think, extremely interesting for specifically for patients with MYD88 mutations. Again, very important to know your genomic profiling, as treatments are coming down the road, are actually going to be focusing on which profile you have. So talking about personalized treatments, patients are going to come over, they're going to get typed, and then we will decide which treatment is the best for you based on your genomics, based on your clinical factors, based on your other comorbidities, based on the symptoms. Highly personalized, highly personalized. It's not going to be an easy job, right? But I'm up to it. So to finalize, I think these are just the most important messages. I mean, MYD88 as a mutation is present in over 90% of patients with Waldenstrom's. It defines the disease in my mind, and I think it's an important test to know if you're a patient. Ibrutinib is a BTK inhibitor. It's safe, it's effective. There's a second study that just came out from Europe using also Ibrutinib in patients who were refractory to Rituximab. Same results as Dr. Trion's results, the same results, so highly efficacious. But again, it all depends on which mutations you have. You can be the great, the okay, or the no way group. And obviously, there are ongoing trials with new BTK inhibitors, BCL2 antagonists, and planned trials with CD38 antibodies as well as CXCR4 antibodies. So with that, I really want to thank you for your attention. And I'm happy to take questions. Please.
So in your two gene markers that you found, the mutations, are those mutations something that you're born with, or are you actually mutating over time?
Good. That's a great question. So these mutations are called somatic mutations, which means you have them in the malignant cells. But if we take, for example, a sample from your the buccal mucosa or the eggs or the sperm, it will not be there. So it's not mutations that you are born with. Those are mutations your cancer cells develop, and they drive. I think they drive the disease up to some degree. Now, why do they develop that? That's a different question. But we know that happens.
Is there any research being done into what's causing the mutation?
Well, it's very difficult to do that because you will have to follow people from birth and do whole genome sequencings every year. And to have about 3 patients with Waldenstrom's, you need to follow about 100,000 people. So yeah, I don't think anybody's going to fund a study like that. So we can do retrospective studies and try to get a sense, but obviously none of those will be confirmatory to actually know why. I hope at some point it will be done, but at least at this moment, just because of the methodology of it, it's just impossible to do. Yeah.
I have a question for you. Can you explain the test SGPG-MAG and SGPG-MAG index and
Yes.
extremely high numbers, like it says it should be less than 1,600, and mine was like over 25,000, and another one 102.
Yeah.
or
Yeah,
20,000.
so what you're referring to is to the antibodies that are associated with neuropathy in patients with Waldenstrom's. There are a number of different antibodies that can mediate neuropathy in patients with Waldenstrom's. One of them is called the anti-MAG antibody. The other one is the SGPG antibody, and which stands for sulfatide. And the other one is actually GM1, which is ganglioside. So there are different antibodies. Now, the issue with the antibodies is that if we measure antibodies on everybody who is asymptomatic, very likely we'll find about 5% of people who will have the antibodies, but they will have no symptoms associated with that. So the presence of the antibody alone doesn't really mean much. But if somebody who actually has neuropathy, we need to be very careful too, because the antibody could be present, but the titer cannot be high enough for us to be concerned of a relation. In your case, if at any point your antibodies were over 100,000, I think there's and you actually have symptoms of neuropathy, I really think there is a connection there. Having said that, the connection between the blood and the symptom needs to be confirmed through a study called EMG. An EMG study is a needle test that the neurologist performs, in which electrical waves are being sent down your limbs, and they actually see how your nerves conduct the electricity. And the typical neuropathy associated with Waldenstrom's tends to be demyelinating, which means it should give you a myelin. There's specific patterns associated with myelin changes versus axonal changes. This is actually in the nerve. There are different organelles within the nerves that can be affected. So when we talk about neuropathy, we need to be, in my mind, very careful, because we could say that the disease is causing neuropathy, and it's not. And it's very easy to basically just connect the two, and at the end, there might not be no relation. So our testing tends to imply a neurology evaluation, EMG testing, spinal MRIs if it's necessary, then getting all these blood work to make sure that we are not missing, B12 disease, Lyme disease, HIV, diabetes, and much more common causes of neuropathy. And if we are able to rule all that, and the antibodies, obviously anti-MAG, SGPG, and GM1, if we have all that done, and then all the pieces fall into the right place, then we end up usually with a sense of likelihood. There is high likelihood of relation, there is an intermediate likelihood of relation, there is a low likelihood, and then we move forward just based on that. So SGPG is one of the antibodies associated with neuropathy, but it has to be taken in the right context.
Yeah, how does it relate to the MAG? Because the anti-MAG, and they know it finds caused by the cancer.
Mm-hmm.
The anti-MAG has been relatively low with treatment, but then all of a sudden this SGPG is just off the charts.
Yeah, so the titers do not relate to response, and that's something I want to make very clear. Yeah, it doesn't.
MAG does, but this doesn't.
None of them. So what the titers measure is the affinity of the antibody to your nerve endings. And that affinity, regardless of how much you have, is going to be the same, right? So if you have a very powerful titer antibody, and that power is not going to change regardless if your IgM is 5,000 or 1,000 or 500. So the titer itself doesn't really mean that you're responding, and that's why we don't measure it. We measure it to make the diagnosis, but we don't continue to measure it to see if you're responding or not. The best manifestation of response is obviously the IgM dropping, which is a response to the disease. Okay. And there's an association between your antibody and the IgM. And obviously wait long enough for about a year and a half with a very nicely suppressed IgM to see if there's a neuropathy improvement with time. The issue with neuropathy is that it could not respond, right? Because the damage is already done, and whatever damage is done, it cannot be recovered. But we will not know, there's no way to know that. And so it's very difficult to take care of patients with neuropathy because we don't know that. Number one, we don't know if the patients will respond, or meaning the IgM will go lower. And even if we do that, we don't know if the neuropathy is going to get better down the road, right? So it takes a conversation, a long conversation, and to actually understand and put it all in the right context. Fortunately, I think a good proportion of patients do get better with treatment, but not everybody gets better with treatment.
Thank you.
No problem.
Thank you. There are some of us that are watch and wait, and then people have been treated with various of these drugs. But it sounds to me that whether you're in a sort of a smoldering Waldenstrom's or you have been treated, having a study to see if you've got
D88
and CXCR4 is a necessity. Am I understanding that?
Yeah, well, the thing is there are a couple of positions in here, right? We have, our position is, yes, you should know that, because at some point treatment will be necessary and it's better to know this information very early on. Some people can tell you, well, if you're not going to be treated, then why do you want to know? Why do you want to know? When it comes the time that you need to be treated, then that's the right time to know, right? And there are two different positions, and I don't think one is wrong or the other is right. I don't think that's the case. It's just that some people want to know right now what they have, and some people can wait a little longer to know what they have, right? So in those scenarios, I don't think there's any clinical benefit of knowing right now if you have it or not, from my perspective. But I think it's important to know. You don't have to, but I think it's important to know that.
How do you go about getting it?
Sorry?
How do you go about getting the test?
Well, the MYD88 mutation is basically done in many different centers right now. Actually, most of the laboratories out there are running a MYD88 testing. The problem with the MYD88 testing is that how sensitive is it? Sensitivity is a problem, because if I tell you, well, I do have one in 1,000 of my cells have MYD88 mutation, and you run a test that only detects 1 in 100, you will be negative, right, in that test. But if the test goes 1 in 10,000, you will be positive, right? So the sensitivity of the test is very important. At the Dana-Farber, our sensitivity goes in 1 in 10,000, which is one of the highest. Many of the other centers do about 1 in 1,000, which is pretty good. I'm not telling you that they are bad tests. But if you have a negative test with a sensitivity that is not great, then you don't know if really you don't have it. When we find it, it's no problem. It's there. We found it. But when you don't find it, you always have it. You're always going to be thinking about, well, is it because it's really not there, or it's just I have it at a level that is undetectable based on the test that they run, right? And that is always an issue. So my recommendation is, get a bone marrow biopsy done, and have it sent to Foundation. If you don't want to go to Dana-Farber, got it sent to Foundation 1. I think their sensitivity is as good as ours, but I think still our test is a little bit better. And the reason for that is because when you do the Foundation 1, they're going to take your entire sample and going to run the test on that sample. When we do it at Dana-Farber, we separate the malignant cells from the other cells, and we run the test on the malignant cells. So our sensitivity tends to be even deeper just because we separate the bad cells from the good cells. So we actually, the needle is the same size, but the nest is much smaller. Does that make sense? You will have to go there, yeah. Too. Yeah, no, but I mean, but again, Foundation One is really, really good test. I'm talking about, like differences of like, millimetric differences of degrees of detection. So I don't think there's going to be, clinically speaking, a major difference. So Foundation One is really as good as you can get, and they do the CSF mutations too.
This is bone marrow test or blood test?
So if you have never been treated,
Right.
your blood could be as good as the marrow. But if you have received some type of treatment in the past, then your blood really loses a lot of that sensitivity.
What you need if you've never been treated by blood. rather
You
than
could,
bone marrow.
but again, if the test is positive, we know you have it. If it's negative, we are not certain that you don't have it, and that's the issue.
Is the bone marrow a better, like gold standard versus?
Yes, the
blood?
bone marrow is the gold standard.
Okay, so if Dana-Farber, you do bone marrow?
We do bone marrow biopsies, yeah. And somebody's telling me, I really don't want to have the marrow. I want to try to see just if I can do it from the blood. I'm saying, okay, no problem. But if it's positive, it's great. But if it's negative, then you need to come back and get the marrow anyway, right?
You mentioned that if you had a treatment like bendamustine, you could have another one if it didn't work. If it does work beautifully, that or something else, do you go back to it some later time and have it again?
Yeah, some people do that. Right now we do have so many options that we don't feel that it's necessary to do that. But some people, I think in the past, when we only had chemotherapy, if one chemotherapy worked better than others, then you will continue doing that until it runs out. But the studies that have shown is that the second time around, the benefit is never the same as the first time around. So you're going to probably benefit from it, but the benefit will not be as lasting as the previous one.
Is
So,
there one thing that changes with age or not?
no, I don't think it actually changes with age. I think it changes just because of either the mutations that you have or the previous exposure that you had, but not just because you age, you will be less or more likely to respond to some treatments. Good. Any additional question at all, please?
I have a question.
Of course.
If my, red blood count and hematocrit and hemoglobin is falling, is that a sign that I should be considering treatment or?
Yeah, so again, blood counts dropping is actually the most common reason why we treat patients with Waldenstrom's, specifically when the hemoglobin goes below 10 or the platelets go below 100. But again, even in that setting, I would like to make sure that there's no other explanation for the anemia. So iron deficiency is very common. Vitamin B12 deficiency, folic acid deficiency, those are common things. So those are things that I would like to have ruled out first. Because if what you need is an iron infusion, I'd rather you have that than a chemotherapy round, right? So I need to make sure that the anemia is not due to something else.
Well, I had a doctor tell me that, or maybe it was the pharmacist, that women over a certain age don't need iron, and I thought that was the strangest thing.
Well, what happens is, because of the menstrual cycle, most women during their childbearing age, let's put it that way, tend to be a little bit on the lower side in terms of iron. And when patients go through menopause, then obviously they become less likely to be iron deficient, but they can still be iron deficient. I mean, that the fact that you are less likely doesn't mean that for sure you don't need it. You get tested. If you're deficient, then you need it, right? What I don't agree with is to actually give patients iron blindly and say, oh, you're anemic, yeah, let me get a bit of iron, right? So I'd rather test. If there's a deficiency, then you give it. If there's no deficiency, then why am I giving something that there's if there's no evidence of a clear deficiency?
I'm sorry, you mentioned a foundation where you could get
Yeah, that's the name, Foundation One. That's the panel. It's called Foundation One.
Foundation One.
That's the name of the panel, and it's sent to a central laboratory. And most laboratories like Quest and they tend to have LabCorp. They basically have paired up with this foundation. Now, most insurances will cover it as long as the doctor is very clear on what is the need of it. So you need to talk to your doctors and make sure that they document the necessity very clearly. So otherwise, you're gonna get hit, and it's not a cheap test.
You mentioned BTK inhibitors.
Mm-hmm.
What
Yeah. So essentially, when MYD88, I was telling you, MYD88 gets activated because of the mutation. It binds to another MYD88. Once they're bound, it activates BTK right inside the cell. And BTK with MYD88 form what we call the mitosome. Mitosome is a group of molecules that basically come together upon activation to basically drive the survival of the cells. So this mitosome is driven by MYD88, BTK, and there are other molecules in there, ITK, IRAK1, 4, HCK. All those are potential targets, to be honest with you, but the core of it is BTK. So the activation of MYD88 is mediated mainly by BTK. Now, CXCR4 mutated patients, they have the MYD88 mutation, but also they have a CXCR4 mutation. That CXCR4 mutation is actually a little bit independent of the mitosome, and that's why we believe that by blocking this pathway with Ibrutinib, doesn't really completely blocks the CXCR4 pathway. That's why I think if we block it separately, as long as we're blocking BTK at the same time, we might actually have a synergistic effect.
You know what I noticed with oncologists down here, maybe it's everywhere, I don't know, but they're not really real anxious to try new things.
There are many reasons for that, and I think the main driving reason is, well, you know, we know this works, and we know how it works, and then I don't feel comfortable trying something that I don't know if it works well. Because I mean, this data on Ibrutinib is great and fantastic, right? We would say, but how much do we know about Ibrutinib in the long term? 4 or 5 years tops, right? So you could say, well, is something really horrible going to happen on year number 10? We don't know. I cannot tell you that, right? So some people say, well, with Rituximab, we have used Rituximab for 20 years. We know that there's no long-term problems with it, right? We know Bendamustine for the last decade. We know Bortezomib for the last decade. So we know those medications really well. And and there's a point. I'm not telling you that they are wrong. I think it's a point. It's just that you as a patient, you know, need to balance that out to actually be able to, you know, be counseled appropriately. One thing is people, doctors counseling you, but at the end is your decision on what it makes sense in your mind. And there are some patients who will be very careful and tell me, you know what, I don't want to try anything new. I want to try something that I know is going to work. And that's fine. I have no problems with that, you know, but I counsel the patients and then we talk about that. And it's a decision made jointly, let's put it that way.
My Ibrutinib, when I go to get it, it's Brica. Is that a generic for it?
Imbruvica.
Imbruvica.
Yeah, no, so Ibrutinib is a generic, Imbruvica is the brand name.
Okay.
It's the same thing.
Okay.
Yeah, it's the brand name. So right now the patent is still under, you know, is sequestered still by Pharmacyclics or AbbVie. So that name is not going to change.
Okay.
So, and the reason is when we give lectures as academicians, we try not to use brand names.
Oh, okay.
But that's the only reason.
Right. I knew it was the same thing, but.
It is the same thing. Yeah, Imbruvica. Yeah.
Earlier you said that people have different IgM. Just like mine was, I've been diagnosed 7.5 years, never had that treatment. But mine started out at 4680, and it's slowly got up to about 5,000 over 7.5 years. That slide that you showed that Rituximab only, if you got over 4,000, you should not be a single agent. Does that apply to somebody that's got high IgM?
I think so. And again, the thing is, we don't know who's going to flare and who's not going to flare. And we don't know how big of a flare is going to be. Sometimes we have flares of 25%, in which the IgM goes from 4,000 to 5,000. That's not bad. But then we have, you know, flares of 300%, in which the IgM goes from 3,000 to 9,000, right? We don't know who's going to be, which case you're going to be, just by looking into your face, or even looking into your genes. I mean, there's no way for me to know if you're going to be the ones who's going to have a massive flare. So, for that reason, we just want to be, you know, universally precautious. Let's put it that way.
Rituximab seems to be the most conservative first-time treatment.
That's right, and I think that's the reason. So it has the longest track record. Is relatively easy to give, right? And the patients are in the infusion room, which is obviously an income for whoever provides infusion. Pills are not income for treating physicians. Sitting in the chair getting chemo, that's income for physicians. So I mean, there are many reasons why this is the case. And again, I'm not telling you that is the wrong thing to do. You know, it's just based on what I know, I'm less likely to use it alone. There are some patients in whom I still use it alone, but it is not in patients who have high IgMs specifically.
I was first treated with Rituximab in 2011, and it worked great.
Good.
And if I am treated again, she wants to treat me with Rituximab again because that seemed to work so well.
Good.
Am I eligible to be on the two? You said the bendamustine, right?
Yeah.
Worked well with
You are eligible to try anything you want. Yeah.
Okay, good.
Yeah, I mean, obviously, if there's a clinical trial that is only for patients who have never been treated, then obviously you don't qualify because you had treatment already. But for any type of study in which there is a relapse disease, you would qualify for that. And for any of the regimens that I put in here, you're qualified for those too. Now, if you did so well with rituximab the first time around, I don't see any reason why you should not be on rituximab the second time around too. It's not a bad option, right? It's just that I don't know your specifics in terms of, you know, how symptomatic you become, what is the reason for this, how your IgM gets. I mean, there are other, you know, more specific reasons that will make me think about that a little bit more.
Well, I had a 2,700 count IgM, and then it went down to 1,900, which I thought was strange. I didn't know it ever dropped.
Yeah.
And now it's back up at 22.
All right. So actually, you responded, but you responded. I mean, that's what we call a minor response, and but it lasted, which is a good thing. So one thing is the depth, and a second thing is how long it lasts, right? So there's a study that we have done that showed that the bigger the response you have, the more long-lasting treatment more long-lasting time without treatment you're going to have. So if the next time around you can have a combination that will bring your IgM even further down, you might actually experience even longer time, you know, without needing treatment.
Two questions.
Sure.
The first question is a clarification. So when you share with us in terms of treatment, is that considered as what I call control, or are we curing the disease?
Mm-hmm.
The second thing is, if it's more of a controlling of the disease, then when you get into a maintenance phase where I'm getting into, what should be the maintenance?
Yeah. So we never use the word cured for Waldenstrom's because we have never really cured it ever, right? Not even with high-dose chemotherapy, transplants. I mean, you know, so what we do always is controlling the disease the best we can. Now, when we talk about maintenance, we talk about patients getting some type of an intensive treatment a little early on, let's say, you know, either bendamustine Rituxan or bortezomib Rituximab, 1, 2, 3, 4, 5, 6 months, and then kind of getting quarterly treatments just once every quarter for a couple of years with just Rituximab alone. So that's the maintenance that we're talking about. There is some people saying, well, why don't I do bendamustine Rituxan and then I give you Ibrutinib maintenance? You know, some people think about that, right? But there's no indication for it. I mean, the indication for Ibrutinib is in patients with symptomatic disease, right, who are progressing. If you have responded very nicely, you know, then you don't meet that criteria, right? So typically the maintenance that we talk about is Rituximab every 3 months for 2 years, up to 2 years, in patients who had received Rituximab-containing agents at the beginning. No other regimen at this time has kind of a maintenance phase. With daratumumab, we're trying to do that too. We're doing the weekly for 8 weeks, and then every other week for 16 weeks, and then monthly for about a year. So that part, that monthly, is what we call the maintenance phase for that, right? So maintenance means different things, depending on which agents you are talking about.
I was diagnosed last year, done Velcade, dexamethasone, and rituximab. Came from over 7,000 and anemic. My hemoglobin and red and platelets were all bordering on transfusion, although I was working 12-hour days.
Yeah.
So now I'm down on this. I was hovering. I kept going between about 3,044, 3,044, and 3,044. So I'm not pushing down farther.
Mm-hmm.
My hemoglobin hasn't come up, but my platelets are back up. My red is staying kind of down.
Yeah.
I'm working, you know. So I don't know. Ibrutinib has been suggested, but I'm 56, and I'm a little like we don't know long term yet.
Mm-hmm.
I'm operating okay. I'm kind of like maybe go back on watch and wait.
Yeah. Yeah, I mean there are different options, right? One option is to, and it all depends of how, what do you feel, how do you feel. So you have the chance of continuing BDR. What the regimen you got is called BDR. So you are one thing is to continue BDR as maintenance and see if with time you're gonna get maybe a little bit more benefit. And you can just exactly. No, I agree. So if that's the case, just rituximab alone maintenance. That's one option that you could say, well, let's try some maintenance and see if I can get a little bit more benefit, right? The other is just, as you say, do nothing else. I want to stop right now and see how things go, and when things progress, then I'll consider something at that time. And the third option will be to switch and try something different. But if you are asymptomatic, then I feel less prone to doing that, because that means you are burning the bortezomib rituximab bridge, and you are already getting a second treatment. That's it. So I think you could probably maybe bank a little bit more, with kind of consolidating the treatment. So in you is the type of patient in whom you have maybe a 50% decrease on your IgM, a little bit of increase on your counts, but not completely. Maybe somebody that I will consider, getting some type of maintenance on you, and much more. I will favor that more than doing nothing. Now, that doesn't mean that doing nothing is the wrong thing to do. It's just what I think you could potentially benefit from.
Are any of the trials able to be done in your home with your home doctor if you come out?
If it's a clinical trial, it has to be done in the center where this trial is being done, unfortunately. Yeah.
Because Waldenstrom so far has not been curable, is stem cell not a good process? Or I haven't heard you say anything about stem cell.
Yeah, so transplants, there are two types of transplants, right? The transplants in which you get your own cells back, and some transplants in which you get somebody else's cell back. So the ones that you get your own cells back is called autologous, and the ones that you get somebody else's cell back is called allogeneic. Allogeneic transplants are not something that we use, and we are actually, it's funny because we're actually generating a multinational position paper on transplants in Waldenstrom's. We're working on it right now, right as we speak. We had a number of, teleconferences and web conferences to try to put our ideas together. So allogeneic transplants is not something that we are going to recommend, I don't think. So autologous transplants is different. Autologous transplants means patients get a high dose of chemotherapy, and your cells get collected from your own cells, and the chemotherapy basically ablates all your immune system, and then they infuse those cells back into you, kind of a reset of your immune system up to some degree. We do that a lot for myeloma, Actually, myeloma has shown to be better than chemotherapy alone. If you chemo transplant, it's better than chemo alone. Even if the patients get into very good responses and they are both at the same level of response, transplants are always a little bit better. So for Waldenstrom's, we're considering that too, but the issue is that we have so many options, right? So we have bendamustine, bortezomib, carfilzomib, Ibrutinib, and all this. So we have so many options that transplanting somebody right after the first cycle of treatment or right after the second type of treatment is not something we are going to recommend. So I think what we are going to end up recommending is autologous transplants should be considered for patients who have received at least 3 lines of treatment, including Ibrutinib. If you have gone through 3 different lines of treatment and also Ibrutinib, then maybe transplant is not a bad option at that moment, right? And that's for autologous. But again, the position paper has not come out yet. I don't know exactly what is it going to say, because we are 10 clinicians, 10 transplanters, and we are fighting over what to do, what we need to do. But we're going to try to come up with something that actually makes sense as a guidance for everybody. So at this moment, as it stands, transplants are not our best options. Let's put it that way.
And it'll probably be in that position paper an age cutoff where you won't recommend it at all.
Well, it's hard to say, because the age cutoff for transplants has changed in my lifetime, and I think it has to do is the age of the director of the transplant unit. You add 10 years to that, and that's the age. So when I started my fellowship in 2005, which is just a bit more than 10 years ago, everybody was like, yeah, 65, that was the cutoff. Right now it's like 72. right? So it's increasing as time goes by, and physicians feel more comfortable, treating patients, and patients also, understand, a little bit better what needs to be done. So that's changing.
Thank you. Is there a better time to harvest?
Yeah, and that's a question, right? I mean, people. So most of the treatments that we are promoting here, that we talked about, are not stem cell toxic. The large majority are not. So bortezomib doesn't damage, ibrutinib doesn't damage, carfilzomib doesn't damage, rituximab doesn't damage, even cyclophosphamide doesn't damage. Fludarabine does, so that's why we don't typically recommend it. With bendamustine, the jury is out if it affects stem cell toxicity or not. The Germans have done studies that show no stem cell toxicity, but because of the nature of the molecule, here in the United States, we're always concerned that it could potentially be stem cell toxic, but I don't think there's actually solid data to suggest that at the time. So most of these regimens are not stem cell toxic. So if you know you're gonna give something fludarabine, maybe at that moment might not be a bad idea to get the stem cells. But if somebody's gonna just get the regular treatments, the stem cells can be collected at any time.
What's the shelf life on the harvest?
About 10 years.
10 years?
Mm-hmm. About 10 years. So I have a patient who did the harvest, and he said, should I be transplanted right now because my stem cells are gonna expire? And I'm like, but you're doing fine. Right? I mean, you really wanna have a high dose chemotherapy that can damage your heart, your kidneys, your liver, right? Just because your stem cells are expiring. So, it adds an additional level of complexity to something that shouldn't be that complex. So that's why we're not recommending it at the moment.
Just a thought on that. I had 14,000 collected, used 5, donated 4, I still have 5. Still have 5 months stored. When those get to expiration, can you use those for research? Can I reallocate where those, right now they're supposedly stored.
Well, I mean, the thing is, it all depends at what time the stem cells were actually, gathered.
It was after
Yeah.
treatment and relapse.
So yeah, exactly. So when the stem cells are gathered at a time in which your burden of disease is low,
Yes.
then those stem cells are, not likely to have disease in them, right?
Well, they would be.
Exactly.
There was
There will be some, but not all of them. So that's why, for research purposes, I don't know how useful those will be. But, you can always get in touch with different institutions, and you can email me when the time comes.
Overall might be a good person.
Exactly, with Irene or even Steve in their laboratory. So it has to be a laboratory person, and if they wanna have some of that.
Something.
Yeah.
Do that.
Yeah.
Is there a specific process to become involved in any of the studies you're talking about?
Yeah, you email me.
Pardon me?
You email me.
Oh,
That's it.
that's pretty simple.
It is. Yeah, exactly. So, well, obviously, the fact that you email me and then I can provide more information, that doesn't mean, number one, that you qualify. That doesn't mean that you're enrolled. Doesn't mean you're enrolled. You're just getting information from them. There's a lot of, the IWMF is a good place to actually look for clinical trials. If you actually go to clinicaltrials.gov, you can actually just basically search all the clinical trials that are available there. You can get information from those too. And obviously you can contact the principal investigators because the principal investigators are listed in clinicaltrials.gov. The investigator is there, their email address, the phone number. So you can just inquire, but that doesn't mean you actually will participate or will actually qualify for them. For that, you need to actually undergo what we call a screening process, in which you actually get into the center, blood work, bone marrows, CAT scans. We do a number of different testing. And then at the end of that evaluation, we say, yeah, you qualify, and these are, or you don't qualify. And people might not qualify just because they are fine, right? I mean, they are not anemic, they are asymptomatic. They would like to be considered for the study, but they don't really meet any criteria at the moment to be treated. So.
On your email, it's your
Yes, Jorge J, and then there's an underscore.
underscore.
Yep.
Are you currently, or is anyone currently doing excuse the bad pronunciation, venetoclax?
Yeah, so we're actually completing. Yeah, we just completed accrual for that study. We're very excited. The toxicity is minimal. The efficacy is there, and I think we wanna like to combine venetoclax with ibrutinib for a future study.
And then for ASH, you should have some reports on the clinical trial studies and how they're going.
Sorry?
Did
Yeah, no, at ASH is a little bit too early, but I think by mid-year 2018 we should have.
But you'll at least have your plan or how many people you have enrolled or whatever.
Yep, yep, we should.
The 3-pill-a-day regimen for Ibrutinib
Mm-hmm.
was determined to be the best shot to start.
Mm-hmm.
And you said that they may want to double, triple up or whatever, and it may help for other things down the road. Has anything been done to, if you reach a level with these 3 pills a day, to start a reduction to see if
I see.
that makes
Yeah, no, we haven't, and we haven't formally. So what happens is the level of Ibrutinib that is reached on your body depends on how much Ibrutinib you take, and that basically determines how much of the BTK is actually blocked. So if you take 3 pills per day, the blockage of BTK is about 95%. If you take 2, it's about 80%. If you take 1, it's about 65%. So some patients, I believe, are going to do fine with just 2. The problem is that we don't know who is going to be that patient. We don't know that. So that's why, to be on the safer side, we always start at 3. The only reason in which we decrease the dose from 3 to 2 is because of toxicity.
Because of what?
Toxicity. If you're having a bad side effect, something that is not resolving, sometimes we decrease from 3 to 2. And the large majority of people that have gone from 3 pills to 2 pills have done fine. But we have not formally evaluated, Now, what we know is that even if you get to a 90% decrease on your IgM, which is a very good response, if you stop Ibrutinib, within a week or 2, the IgM starts coming back up. So we know that treatment should be continuous and indefinite. We know that. The best way to answer your question will be to take a group of people on Ibrutinib, seeing the patients are responding, and then separate at that moment a group that will continue on 3, and then a group that will go to 2, randomly, right? And then see how they do in terms of toxicity or efficacy down the road. That would be the best way to do it. But I don't think pharmacyclics or AbbVie will be too keen in running a study of that nature.
But how often would you measure that? Every month, every week?
Measure what?
Say the IgM, if it worries you.
Oh, no, the IgM, we check it on a monthly basis for the first 3 months and then every 3 months afterwards. And whenever we switch treatments, let's say from 3 pills to 2 pills, we do monthly checkups, and then if everything remains stable, we go back to every quarter. But we do not measure the BTK blockade.
Right.
That is not, there's no clinical test for that. So that is not something that we can do.
The result.
Exactly. In clinical trials, you can do it, right, because it's research. But as part of clinical care, we do not have validation for that test.
Those percentages you gave for the effectiveness of 1 pill, 3 pills, 2 pills, so forth, had nothing to do with body size at all, like a 250-pound man versus a 105-pound woman?
No, it doesn't.
No correlation?
Yeah, it's like antibiotics. Yeah, it's pretty much like that. You have a target that you have to block, and that's it.
Do you need to go off of it for cataract surgery?
That's a good question. The cataracts typically are not really vascularized, so there's no a lot of risk of bleeding, but still is the eye, right? So, and there's some vessels in the back, and there's some inflammation that could be derived from it. So we do recommend holding it just 3 days, the day before, the day off, and the day after. That should take care of that. Yeah, around 3 days for that.
Does that affect you too much?
Well, most of the patients do not feel any problems, but we do have about 10% of patients who might have some withdrawal Ibrutinib effects. Yeah, which we're publishing a study on that, because really there's not a lot of it out there. But out of our 200 and some people, we have 17 patients who actually develop withdrawal symptoms.
What would it be like?
Different things.
Diarrhea or something like that?
People have fevers, night sweats, chills, pains, muscles, and they usually resolve within 8 hours of taking the pill.
Okay.
Yeah. Any additional question? Please.
This is just a general question. I understood it in your lecture. You said that BCL2 determines how long a cell lives, and some that have a great deal of this are, as you put, immortal.
That's right.
And is this true of all cancer cells that have this?
Actually, about 75% of all cancer cells have overexpression of BCL2. So this has the potential to be used for other cancers. Now, one of the questions that we get asked all the time is like, well, if all the cells have BCL2, if I'm blocking BCL2, what's going to happen with the normal cells? The normal cells have other mechanisms of survival, and the cancer cells are more dependent on BCL2. They're addicted to it. That's the difference with the normal cells. That's why the normal cells can actually, kind of outdo the effect of blocking BCL2.
So have researchers determined which cancers fall into that category?
Yeah, and actually venetoclax is being tried in a number of different cancers, not only blood cancers, but also solid tumors. Yeah, because of that reason. Yeah, from that to being effective, that's a different story, right? The studies are being done. We don't know if it's going to be effective.
Too early?
It's too early.
I just want to thank you, Dr. Still, on behalf of our group. We might be small, but I can assure you there's not a more interested and attentive group than this to your presentation. And you gave us a very complicated subject, which in a very informative way that we understood. And I want to thank you for it.
No, it's my pleasure. And I mean, I think I'm a very big proponent of patients being their own best advocates. And I think knowing more is the best for you, asking the right questions. And we as doctors, we need to team up with you guys to actually, make it work. So, if you have doctors who do not want to collaborate, who don't want to listen to you, and they're not protecting your best interest, that might not be the right doctor, I know some physicians actually feel intimidated by patients with rare diseases because they end up knowing more about the disease than the doctor himself, and that's fine. I mean, it has to be like that. So that's the message that I want to convey, and I don't want you to feel bad when a doctor says, well, you're coming with all your studies, and no, what are you doing? Like, why are you challenging my decision? Right? It's a partnership, and as long as they all understand it like that and work at it like that way, everything's going to be just fine.
We have just the opposite. We've got one that was just thrilled to get with Dr. Treon and consult with him and get
Good.
her Imbruvica way before it was
Yeah.
approved.
The large majority of doctors
We
do.
brought that to him. He didn't know about
Yeah,
it.
no, the large majority of doctors do feel that that the ultra specialized physicians as we are are helpful, but you always find every once in a while these doctors who really they think they know everything, and and probably they don't, right? I don't. I think I understand Waldenstrom more than the average doctor, but for them to tell you, oh, I know everything about this disease, nobody does. We're all learning. This is all a learning process. Thank you very much for your attention. It's been a pleasure.